Hello everyone, my name is Jonathan Umble, and this is my presentation on groupthink. To start off, I just wanted to go over what groupthink is. According to Barnowski, it's a strong conformity pressure that reflects members' attempts to maintain harmony within the group. Um, More simpler terms, what this means is just that when people come together in a group, they tend to believe the same ideas, the same concepts about whatever they're doing. They don't want to make waves. They don't want to go against the group, most likely because of strong interpersonal relationships. Groupthink also has an effect on the acute care setting. We work in small teams constantly throughout the day. We develop very strong interpersonal relationships, and in many times we can develop a type of groupthink that we're all doing something that might not entirely be the way that we should be doing something. Some examples of groupthink in my professional experience is with call bells. Recently, I was on a travel assignment at a hospital where the staff and employees they would not answer other people's call bells because they weren't their patients. It was kind of an unspoken agreement that, when your patient's call bell went off, you would go and see what they needed. But if someone else's call bell went off, you most likely would not find other nurses or aides answering those bells. It's not a terrible system, but there's always times and occasions that the primary nurse or aide is not available to answer this bell, and then it can prolong patient care. A big part of this, I believe, is the groupthink that nurses have, there's certain delegation and there's certain responsibilities that they have to do. They kind of prioritize certain responsibilities over others, and thus we would lose the ability or really the motivation to answer every single call bell, what most hospitals would say is the no pass zone. The setting and environment is, of course, in the acute care setting. It was a small, or actually a fairly large 32-bed trauma surgery floor. And this patient population is in North Philly, and there's a lot of drug-seeking behavior, a lot of different traumatic injuries which cause a lot of pain, so a lot of people are ringing their call bells. Call bells can become quite a nuisance on the floor that I was working on. My role in this scenario is that I am a part of a team. I am a registered nurse. The group would consist of registered nurse, the nursing aide, physical therapists, doctors, case managers, social workers. It can be a smaller group or a larger group. It doesn't necessarily matter the size. But my role in particular is that I am a part of this group. I am caring for usually 4 to 5 patients on my floor, but on the floor, at most hospitals, you have a policy of a no pass zone. When there's a call bell on, it doesn't matter who you are, it doesn't matter what you're doing, you should at least go in and check on them to see what they might possibly need. My role as far as the group think is that after several months of working there, I did slightly fall into their idea of answering call bells that are mostly pertinent to you. There's times that I would, either ignore a call bell or walk by it because of either, time constraints. I had other priorities, different situations that I would rationalize and go along with the group. I always slightly felt bad for it. I never really wanted to do that, but it is easier, and it was kind of the groupthink ideal that I fell into. Being a nurse, we have, many different responsibilities, so it was easy for me to rationalize with the group and not answer some of the bells that I probably should have. So there are many different behaviors in this scenario of the groupthink that I expressed earlier. The overall behavior of the group is that they were okay with it. It seemed to be a system that worked for the nurses and the aides. You were able to answer your bells. You were able to be more helpful. You would waste less time by doing it instead of running into a room, getting someone else who, the bell was actually, mostly for, whether it be giving pain meds or, if you don't know that patient very well, you don't want to risk causing patient harm. So the group was pretty on board with this whole answering your own bells. My personal behavior was that it was slightly strange. I worked at two different hospitals that were very adamant about the no pass zone. If you walked by a room and your manager or someone saw, it was frowned upon. So I was coming into this as it being very unique or different to me. But on the floor, there was definitely warning signs. And according to Barnowski, there are three different types of different warning signs. There's 8 total, but they're broken down into different types. So I had what I thought to be at least 3 different examples from all 3 different types. So the first type, type 1, it's an overestimation of the group. So no one is getting called out or punished for ignoring these call bells. So it continues to happen. This is an illusion of invulnerability. Because there's no sort of punishment for doing this, it's more welcomed and almost encouraged by the group. Next, type 2, which is kind of described as a collective rationalization. The rationalization of the group, the way that they think, they're rationalizing why they're not answering certain call bells and answering others. It hinders the possibility of any change occurring in this groupthink. In addition, there's type 3, which includes pressure towards uniformity. We work in a small team. We want people to work together. We want people to get along. When the majority of the group is doing something that causes a direct pressure from others on the floor, it influenced me to join the groupthink of answering the majority of only my bells and ignoring others when it best suited me. In this scenario that I stated, the idea of groupthink revolves around all of those within a group conforming and following along. When I had joined the floor as a travel nurse, everyone was already a tight-knit group, and everyone had very positive relationships with each other. It was a very trusting group. So when I came in, I felt like I had to kind of follow the way that they ran things. So for a while, I was conforming to their way of answering call bells. It did make it very, it did actually make the day easier because being on a trauma surgery floor, having 5 patients, we deal with trachs, chest tubes, peg tubes, tube feeds, JP drains, wound vacs, paraplegics, all of these different things that cause very, time-consuming work. So it was easy for me to rationalize and not, answer certain bells so I could have more time to do what I needed to. According to a study by Milo, we are more likely to trust our colleagues when their clinical reasoning is similar to our own, and we are more susceptible to groupthink when working with people that we trust. So as I started to develop a relationship with some of my coworkers there, I felt more inclined to follow their lead. I still do my best to answer any call bells that I can or whenever I see them. But it's still part of that group think that I did in a way conform, and mostly because it allowed me to do more of my work, but still at what price? It did cost, the patients. The patients are the ones who are really at risk here, which is something that I had to think about while doing this presentation. There are always effects with groupthink. The first thing I'd like to get into is with the individuals of the group. In my scenario of answering selective call bells, it really did help me personally as far as time management. It took smaller tasks off my plate, especially because the majority of the group had already been doing this. So I was answering a lot of extra call bells, mostly because I wasn't fully acclimated to the group, or I didn't have the relationship with the group that most of the other members in the team already had. So for me, it actually helped me get some of my work done quicker, and it allowed me to have more free time to work more specifically with my patients. But the overall effect of the group, I feel, was a negative one. It allowed people to be more lazy. If they saw a call bell on and weren't busy, going off that assumption, they wouldn't answer the call bell. So if everyone's assignment can be different, if you have an assignment that's heavier and your call bells are going off and you can't get to them, you wouldn't be able to rely on your team quite as much to help you. And in addition, I just feel like the group dynamic of having a team on any sort of acute care setting on any floor, you need that support from others who aren't directly in a patient's room or currently doing something, so that the team can work efficiently and care for all of the patients on the floor equally. The biggest effects of the groupthink in this scenario, I believe, is for the patients. We kind of get into our routines of assessments, documentation, medication, care planning, and discharge. I mean, we kind of just get in this routine and we do these tasks, and we don't always think that something could be severely wrong with one of our patients. You never know why a patient is putting on a call bell, and if the time that it takes for someone to answer that call bell is being delayed maybe 2, 3, 4, 5 minutes, a lot can go wrong on a floor with trauma surgery, with chest tubes, trachs, some of these things that are allowing our patients to remain on our floor and be healthy to get better. So I think the majority of the effects of the groupthink, while it does sometimes help in the short term as far as time management, getting through your shift, getting everything done that you needed to, in the end result was that patient care was being a much lesser quality than if everyone was actively seeking out answering call bells, no matter whose patient or whose assignment they were in. Furthermore, I put in this presentation some methods to preventing groupthink. In this scenario, one way that we can kind of change the perception or the way that we answer call bells is receiving outside help. It's by pulling people who aren't so closely involved in the team, who don't have those interpersonal relationships, who don't already have those concepts of how you decide what call bells you answer. Bringing people in who aren't a part of that can kind of stand out and show to the rest of the group no call bell should go unanswered. In addition to receiving outside help, you can also appoint someone to play devil's advocate. Playing devil's advocate really is just raising questions or concerns about current practices, such as, why are you not answering that call bell? Or what's preventing you from answering that call bell? And in a lot of the cases, I feel like there's not a very good reason that they're not answering the call bell besides it's not my patient, which again can lead to patient harm or decreased care for those patients. So playing devil's advocate is another good way to prevent groupthink. In addition to playing devil's advocate, reflecting can also prevent group thinking. Taking several days to kind of contemplate about the current concept of whose call bell that you answer and whose you won't, and thinking about how that affects the patient directly, reflecting on this issue can also lead to more positive measures of getting out of this group think of only answering your own patient's call bells. So that's the end of this presentation. Thank you guys all for listening, and I hope you guys all have a good night.